Okay, look, welcome back to part 2 of our panel discussion on best practice for minimal residual disease testing, including recommendations from the ACS guidelines. We'd again like to thank the panelists for their time today. Clinical services are busy places, and more so during these challenging COVID times. As in part 1, our panelists are haematologists, Dr. Neil Kame and Dr. Edward Theakston, immunologist, Dr. Aruna Kodituwakku, and senior scientists, Gosia Gorniak and Vuong Nguyen. During the second session, we'll look at 3 further areas: statistical performance measures to ensure accurate and robust reporting, limitations to MRD testing, and minimum requirements for the report. Again, questions will be directed to 2 panelists who will each discuss a different area of the topic. Okay, so let's sort of get started. There are a number of statistical performance measures to ensure an MRD assay is fit for purpose and permits accurate and robust reporting. Neil and Edward will discuss these now. Neil, over to you to start, please, if you don't mind.
Thank you, Michelle. I don't have a slide for them. There's a section in the guidelines that deals with this area of statistics. It's not an area that I was particularly familiar with as a haematologist, and perhaps biochemists were more looking in this area. Flow cytometry is undergoing increasing scrutiny and requirements for more robust validation, and flow cytometry, as opposed to some of the biochemical tests, is being referred to as a quasi-quantitative test, and we need to be more aware of the limits of detection, lower limit of quantification, and some way of calculating a limit of blank. And the reason is that a limit of detection is really defines the probability that you're finding something true is greater than the probability of finding background noise. So background noise is really where the limit of blank comes in. And we can do it in 2 ways. We can assume that hopefully that when you perform a flow cytometry test in the absence of a measurand, or so in the absence of disease, or if it's difficult sometimes to find these samples as opposed to biochemical tests, you perform the assay in the absence of a gating antigen, you would hopefully get less than 10 events representing background noise for the purposes of this discussion. But you can also calculate it with a minimum of 5 replicates, and there are formulas in the guidelines for that are taken, that had their origins in the biochemical literature and also the CLSI documents for America, and they're becoming more and more formalised with an H62 document that the Americans are putting together. The limit of detection, as well, is generally regarded as 20 events, would be what the international flow community regards as the smallest amount of events that would reliably regard it as a cluster of disease, with all other things being equal. And the limit of quantification requires more events statistically, regarding T or Z tests. So 50 events would be regarded as the limit of what we would regard as being able to quantify an assay. And so dividing those numbers over a denominator, you'll then be able to calculate the lower limit, the sensitivity of an assay with regards to its limit of detection and limit of quantification. So over to you, Edward, if you could like to start with AML and ALL, the requirements for sensitivity, please.
Yes. I think it's a difficult question to answer simply. The level of sensitivity, by which I would mean the lower level of quantitation, can depend on what you're looking for, what time point is being assessed, and indeed what's actually possible. So starting with BALL, probably the most well-established time point in this disease is the day 29, or end of consolidation bone marrow. Now, this time point is essentially looking at the kinetics of the initial response to therapy. So how rapidly the therapy is clearing disease, or how sensitive the disease is to the therapy, rather than is there any disease left. And so this gives important prognostic information that can determine whether the patient needs an increased intensity of therapy or not. So usually at this time point, we're looking to establish whether there is less than 10 to the minus 4 or 1 in 10,000 or 0.01% residual disease. And although we can achieve greater sensitivity than this, really doesn't add value to what the information that you're providing, because many of those who still have detectable disease at levels lower than less than 0.01% at this time point are actually going to go on to be cured by the standard therapy. And so in terms of prognostication, 10 to the minus 4 is really the sweet spot, as it were, of finding what level of disease is significant and what level is not. At later time points, this can be different. And I think broadly speaking that the later in therapy that you're looking at, you're more interested really in the depth of remission rather than the kinetics of response to therapy. So essentially, the greater the sensitivity, the better. And then you start to come up against what's actually possible. And limiting factors can include not only the number of cells collected or the amount of cells sample required, but you also get interference from normal populations. And so in BALL, if you've got large populations of hematogones and your disease has got a phenotype that's not terribly different from hematogones, it can be very difficult to detect at very low levels. I mean, in general, we're again looking to achieve a sensitivity of at least 0.01%, but it's often helpful to put enough cells through to enable us to go to greater sensitivity, particularly when there's a phenotype that's more easily distinguished from hematogones. Another factor I should point out here is that when we're talking about sensitivity, is when you're reading the papers, it's important to know what denominator is being used, because this can have a significant effect. So in the COG assay, the denominator is mononuclear cells, which is quite different from other denominators, which could include all cells or CD45 positive cells, so not including the nucleated red cells. So this can have an effect as well. And moving on to AML, it's even more difficult because of the lack of standardization of approaches and time points and publications. I think in most instances, people are looking to achieve a sensitivity somewhere in the area of 0.1 to 0.01%, or 10 to the minus 3 to 10 to the minus 4. And most studies tend to use 0.1% as an outcome, and it can be quite hard to get greater sensitivity than this. The app, which was developed for the UK AML trials, can theoretically detect disease down to about 0.02 to 0.05%. But below this, it can be difficult to distinguish disease from all populations, such as including CD7 positive myeloblasts, which are present in normal people, also CD56 positive myeloblasts. CD56 expression can be induced as well, which makes things difficult to interpret. So, and these cells can be, up to 0.05%. So if that's the phenotype you're looking at, you really can't follow them below 0.05% potentially. The current AML-19 study, which uses this assay, uses an MRD threshold of 0.1% or greater post-cycle 2 to define a high-risk population, because this is the most prognostically powerful time point identified in the earlier AML-17 study, which used the same assay. And it sort of illustrates the problem of coming up with an endpoint, because different thresholds can have different meanings and patient subsets. So in that study, they looked specifically at those patients who are MRD positive, but at levels lower than 0.1%. And for example, in patients who are NPM1 wild type, the outcomes in terms of relapse were similar to those of patients who are completely MRD negative. But if you then looked at patients, a different subset of patients who had core binding factor leukemias or who were NPM1 positive, those who were MRD positive at this low level did similarly to those who were MRD positive at the higher level. So in that group of people, it's adding information, and the initial group, the NPM1 wild type patients, that information wasn't adding anything. So the significance of the result is different in different patient groups, and it's often difficult to put this in context. It does certainly help having an assay that's been well studied in large studies. And with some relief, Neil, I'll hand over to you for the next couple of diseases, myeloma and CLL.
Thanks, Edward. I didn't envy you. I don't like AML MRD much, unfortunately. That's not a good endorsement, is it? Myeloma MRD is being called upon to become accredited as a surrogate endpoint for survival, and the achievement of the high standardisation and robustness of the Euroflow next generation flow assay down to 10 to the minus 5 and beyond sensitivity is very important, because myeloma, the therapies for myeloma are getting better and better, so responses are becoming deeper and deeper, but sometimes working out whether a therapy has become successful or not can take up to quite some time, years. And so the need for a surrogate biological endpoint of survival is very important. So the depth of response so far that the International Myeloma Working Group have decided upon based on their studies is at least an assay that can at least detect, has a threshold of detection of less than or 10 to the minus 5 or greater. The old immunophenotypic response of 10 to the minus 4 just hasn't sort of passed muster. There were no patients that were MRD negative at 10 to the minus 4 that didn't ultimately relapse. So in the myeloma world, deeper and deeper responses and better assays to assess that are required. For CLL, the requirement for greater than 10 to the minus 4 sensitivity is becoming increasingly popular. The European Medicines Agency haven't yet decided that that's a valid endpoint, because groups are not entirely sure. You are just exposing patients to more and more toxic therapies to achieve a deeper response with no further benefit. But with increasing novel therapies such as the Bruton tyrosine kinase inhibitors, the BTK inhibitors, or venetoclax, the BCL2 inhibitors, there have been some dramatic responses to previously refractory CLL. And our group at Peter Mac are publishing the value of MRD negativity as we speak, as some other groups around the world. And the requirement for 10 to the minus 5 MRD negativity for CLL, I believe, is coming. So I'll conclude that session. Thank you.
Thanks, Neil. Look, thanks very much to both you and Edward. It was a really difficult topic, so I do appreciate you taking it on. So we can see that it's quite a fine balance, looking at what the laboratory can achieve and what the clinician needs. Now, once you think you have the ideal panel sorted, there are a number of limiting factors to be aware of. These may or may not be biological in nature. Vuong and Gosia will now discuss these with you. Vuong, could I hand over to you first, please?
The limitations that Gosia and I will be discussing by no means are exhaustive, but it's a considerable list. One of the first limitation that one might encounter is the instrumentation itself, which has smaller challenges as well. So one might ask, how many colors do we need to do MRD assessment? I think what we've seen so far in the previous topics is that it's generally advisable to have at least 6 colors in your assay. And one needs to be aware that with the introduction of more colors, one needs to assess how effective these detectors are, as well as whether there's fluorochrome available in these new detector channels. And such that in combination, these two don't reduce or compromise the signal-to-noise ratio. And it's important to have well-designed panels to be informative in order to tease out the abnormal population from amongst the normal backgrounds. And I think we all would like to acquire MRD samples on high flow rate, but we know that there's a significant impairment of the data resolution. So the only viable way really is to run on a low or a medium flow rate. And I might point out that there shouldn't be a cap on the maximum number of events that one should be allowed to be acquired. And we also know that MRD FCS files can amass a significant amount of data. So I think departments need to really have dedicated servers or external hard drives to back up their data. And I think with MRD analysis, laboratories really need to have souped up computer specifications to render and process the millions of events that will be acquired. And I think this is coupled with having a sophisticated analysis softwares with powerful analysis tools to help with the MRD gating strategy. Another limitation that we face right now is the lack of standardization in the clinical sphere, despite there being consensus groups stipulating consensus markers and panels. And this remains at large a major blockade for sponsors and government bodies to support and accept flow cytometry as an accurate endpoint for therapeutic regimens. And this is not so much an inherent limitation of our technology, but more so, I think, the inability of operators and users to compromise, be flexible, and come to an agreement with consensus. There are also challenges in external quality assurance programs. Most of these appear to be international, and so with that comes logistical challenges with shipment of the material overseas. There are also disease-specific challenges such as atypical or heterogeneous aberrant antigen expressions in CLL and AML respectively, whereby these expressions overlap significantly with the normal or regenerative marrows. And certain immunophenotypic files can be quite challenging to track or monitor as well. For instance, the MPN1 positive, CD34 negative, CD117 negative AMLs. And another large obstacle that we face in the clinical sphere is actually post-treatment challenges. An example includes the phenotypic shifts, which means that the phenotype post-treatment is different to that seen at this. This is not so much an issue in mature cells, such as B cells in CLL or plasma cells in multiple myeloma, but can occur in up to 95% of acute leukemias. And in saying that, if one had a well-designed, adequately informative panel, one may still be able to detect a minimal residual disease. We also need to be aware that immune modulation can occur. For instance, with the administrations of steroids in BALL patients, it can lead to up modulation of CD19 and CD20, whilst there's downregulation of CD10 and CD34. And as Edward alluded to earlier, I think we're facing with a lot of different immunotherapies in the clinical world at the moment. And I think, we need to just be fluid and flexible and adaptive, innovative in our ability to assess new markers and implement new panels in order to circumvent these challenges that face us. So over to you, Gosia.
The most compelling and major limiting factor for MRD testing, which is often overlooked, it's the quality of sample that it's collected. And this needs to be conveyed to the collecting doctor that the first pool of bone marrow is required, and no longer the morphology is the priority if you want to test for MRD testing. Because the pool sample limits the MRD detection sensitivity, and therefore the disease therefore the disease that is reported. So of course the major problem is that there can be a bone marrow hemodilution because of the collection technique, and it's advisable that the lab can detect the bone marrow elements in their panels. This is an example how we do it for multiple myeloma panel testing. We assess, there is more population that can be assessed, but in the gating. So you have to look for the hemodilution. So this is a critical point in eliminating the false negative result, or, as I said, the sensitivity of the test in those samples. So the other limiting factor related to sample is that very often we get a low cellularity samples, and the common technique to reduce increase the cellularity of the sample is the bulk lysing, and that in itself creates limitations, because one has to use the lysing reagent which is validated, that preserves cells and requires a minimal washing. If it's not observed, you might have a random population loss, staining intensity can be altered, and it actually can lead to the falsely decreased denominator, which in turn can falsely increase the percentage of your MRD detection, or you can actually lyse your target cells and have a false negative MRD. So this is a very important part to standardize or use standardized lyse technique. The other thing which can be sample related is the incomplete red blood cells lysing, and if you use the nucleated red blood cells as your denominator, this can be the major cause of falsely increasing your denominator. Therefore, you're actually reducing the percent of your MRD detection and falsely giving the number of the burden of the disease and underestimating the depth of the response. So these are the very important limitations which we face, and very often when we get the bone marrow and there is a clot in it, we say, oh my God, we have to, but because we have to, but if there is something like this related to the samples, it needs to be stated in the report, and that will be covered in the next point. But other limitations for MRD testing faced by labs is the time factor, because we all are facing with the increased time for every step of MRD testing, whether this is a set of the tests, some of them that include that need a cytoplasmic staining that will add up to your time. The analyzing requires more time, and the gating as we compare it to the routine. So they're no longer quick analyzing and setting up. So the lab needs to adjust to it, and especially that the delays have to be avoided for obvious reasons, like prolonged sitting on the bench. You will lose your target cells, or if you leave the lyse for too long, again that will impact your sample, and so on. So the lab needs to have a logistic how you start your MRD testing and when, to avoid lost cells. So gating, there's another challenge or limiting factor. You need to have, as Vuong mentioned, the sophisticated software, but not only this, more and more we should really look for a different from normal rather than leukocyte immunophenotype because of the limits which Vuong mentioned before. So recognizing the genic shift or demonstrating the treatment-related loss of antigens. So our complex gating strategies needs to account for those. So the other thing which comes with that is that you need experienced operator. An experienced operator would be asking for a non-rotational staff. This is something which every lab in clinical lab is actually very difficult to achieve. because of the constraints of the clinical labs. So this is something for maybe we can start advocating for flow cytometry and MRD labs, that they really need to have a very reliable hands-on preparation scientists. Otherwise, you're really risking of missing that important population. So not only that non-rotational staff, but knowledge and education. There are all limitations which are facing the currently the lab. And from my perspective, I can say that there is so little time to educate new staff to actually do the MRD testing. This is something which we are facing, and that's definitely have to be looked at by other when you want to implement the MRD as something that you need to have as a factor. So the pattern recognition, which relies on knowledge, it's you can have a help from the software, and there is a sophisticated software with gates for you, but they still rely on an operator to approve or disapprove if it's normal and abnormal. So again, you can use like RCPA in Euroflow, I think, or RCPA. I hope RCPA will come up to the plate and will supply the list mod files for us to gate and see how our gating strategy and recognition of the pattern is going, and educate the younger staff, because that my concern is that younger staff are not as exposed as the rest of us. So I don't know if Vuong, if you've got anything else to add, but I think that will cover the basics, really. Thank you.
Good, Gosia.
Okay. Look, thanks very much to Vuong and Gosia. When I was listening to all of that, I thought it was a very accurate reflection of probably all our laboratories. I know we don't want labs to be afraid of setting up these assays, but as you've seen, it's really important to be aware of all the things that come into play and which you need to be aware of. I know MRD has changed the way that our lab works in a number of ways, and I'm sure you've seen the same. And staffing for us too, and training is a really important consideration as we take on each new MRD assay. Okay, on a more upbeat note, we'll move on to our final topic of reporting. Now, while there isn't a standardised reporting format across all MRD assays, there are some key components recommended in the guidelines. Aruna and Gosia will tell us more about these. Gosia, I'm sorry to have to bring you back in so soon.
That's pleasure. That's pleasure. With the MRD report content, so of the body, what the lab needs to put in the final report, it's apart from obvious sample of patients' details. If your computer system doesn't show on the report collection time and date, that needs to be included. So sample time, collection date and time is the must, or we should also include the indications for MRD while we're doing at what time point. And then if there is a treatment related to disease that might affect MRD, it's probably good to put it in there. So sample quality, as I said, if you notice a hemodilution, so we need to say if it's acceptable for MRD, is this borderline, inadequate, and so on. So antibody panel should be listed. One might include also instrument and software, which is optional, but we need to report recommended sensitivity for the test, and that's very important to actually show what the sensitivity of the test is. So, and the other important part is that you need to include the total cell acquired for the denominator, and please explain what your denominator is in your report. So if you look back, you know what you divide, what your denominator is. Is it CD45 white blood cells, or is it something else that you are using? So that has to be included. Diagnostic phenotype should be stated if it's known, and immunophenotype as well. So for the principal assessment, what you're looking at, are you using leukemia-associated immunophenotype for your MRD assessment, or is this different from normal, and so on? When the MRD clone is detected, that immunophenotype should be listed as well. And the other thing which should be included is the numerator. So the number of cells should be listed there for MRD cells. Total cells already mentioned should be included, MRD percentage, and your calculated limit of detection and limit of quantification. So if I can show the next slide, just an example of our MRD, what we do, yes, here. So that shows here the top part is just the panel and all the things, but the main part which shows the denominator. It's the total, and it explains what denominator we use and the sample quality. So if it was unacceptable, we would say why not. In this case, it's acceptable. And then we will go on and say in the multiple myeloma % of our total nucleated cells. So this is what we've detected is MRD positive. The other thing which needs to be in plasma cells report, you need to report the normal and the percentage of clonal to normal. That's quite this is actually a requirement for multiple myeloma to show the percent. So the clonal cell plasma cell population in this case, we collected 6,369 events, which gives us the MRD positivity of 0.078%, and the phenotype is specified. So you use the Bethesda guidelines of a phenotype description of phenotype as it is different from your normal plasma cells. So when it says DIM CD38, it means DIM as compared to your normal plasma cells, not just DIM like the in general terms. Yes. So when I'm saying when we report it's DIM to normal plasma cells, bright as compared to the normal plasma cells, because one must have stressed that the CD56 can be present on normal as well. So we and the body of the report should state the recommended sensitivity. In the case of multiple myeloma panel, it's 10 to the -5, and the minimal number for a limit of quantifications that is used. The other part which is critical and needs to be shown in the content or the body of the report is your calculated limit of detection, in which you use 20 cells divided by your collected cells. The denominator in this case is 8,167. Sorry, 8,167,209 cells. My God, it's too many cells collected. But anyway, every time in every test, that limit of detection number and limit of quantification number will differ depending on your denominator. So, so in the sense, the sensitivity of the test, which is recommended, it actually goes beyond if you collect a lot of events, which we are all aiming for. So I think I give it to Aruna to explain the next part, which is the conclusion which pathologists do. Thank you.
Second part of the report, which is the interpretations and the conclusions. And it should be written up and endorsed by a pathologist. MRD cells are detected above the recommended sensitivity, that is for AML, 0.1%, CLL, ALL, 0.01%, and for multiple myeloma, 0.001%. That is actually after acquiring at least the minimum number of cells required for that particular test. And it is always better to keep in mind that it is recommended to acquire more than the minimum number of cells to achieve a better CD. If the MRD cells are detected above the recommended sensitivity, we could say MRD positive. If the MRD cells are detected below the recommended sensitivity, but above the limit of detection, that is more than 20 cells, it should be mentioned as MRD cells detected below the recommended sensitivity. And here you could include the recommended sensitivity and the level of detection. So as Neil and Edward suggested, in some cases, this could be an important information. If the MRD cells are not detected at all, or detected below the level of detection, that's 20 cells, it can be reported as MRD negative. So those are the three stages of MRD reporting in the conclusion. In addition to that, as Gosia pointed out for multiple myeloma, it is important to enumerate the ratio between the abundant plasma cells versus normal plasma cells in the bone marrow. A higher ratio is associated with malignancy, that is multiple myeloma versus MGUS. And also important to include the percentage of normal plasma cells. If the normal plasma cell percentage is less than 5%, it can be associated with a poorer outcome. A comment on the sample quality is essential, and its effects on the assessment has to be included. And this was highlighted under the limitations by Gosia's discussion. If there are any disclaimers, such as a diagnostic phenotype wasn't available for a comparative study, that should be included in the report. Finally, there should be a statement to correlate the information that you have generated in the report with the other clinico-pathological findings, especially if there's a molecular assessment available. I think that would give an idea about the final report that should come out of the lab. Over to Michelle now.
Oh, look, thank you very much, Gosia and Aruna. That was a really excellent reply to that question. You've highlighted that when a clinician receives a report, they need to be reassured that all the assay parameters have been met, and if not, that should be explained in the report as well. So I personally found that like a really excellent session. So, but we've come to the end of our session, have completed our panel of questions. Now I'd like to invite Neil, as chair of the ACS MRD Guidelines Committee, to wind up today's discussion with final recommendations. Neil, the floor is yours.
Thank you. So we put some salient features of considerations that a laboratory might want to undertake if they want to take on MRD testing, as we've just cut and pasted them there for you. But to summarise them, it's commitment and money and commitment. They sort of follow around and around. I think the most important thing is the clinical commitment, or the clinical champion. If your clinical unit is strong and wants this sort of assay, you're going to have a lot greater chance of getting the money for it. And the next thing you should have is a buddy. You should have a buddy laboratory. Now, 10, 15 years ago, none of us had buddy laboratories, but I think more and more that's not only a nice thing to do, it's probably going to become a quality requirement. You've got to have somewhere to compare with. And of course, then there are other considerations like cost and workflow considerations. Just remembering, we've not talked about the difference between pre-lysis and post-lysis much. Some assays require an MRD-like commitment. So, for instance, staging of plasmacytomas, some clinicians don't, or laboratory registrars may not realise that you need to do an MRD-like assay to appropriately stage a plasmacytoma, or for investigating Sézary syndrome down to a particular Cesare count in the blood, you may find the laboratory is required to do assays at a higher degree of sensitivity than you might normally have realised. So just be aware that there are other things apart from money and commitment. You're going to have to start thinking about, well, what does the laboratory need to do? Should we be changing our workflow to pre-live everything, or do one or the other depending on assays? So there are many things to think about, including computer systems and the type of staff and the rotations and so forth. So watching that was almost a last-minute inclusion in these guidelines, but that needs to be said and needs to be thought about very carefully if you're going to put together a business case. So thank you, Michelle.
Oh, good. Look, thank you, Neil. Look, thanks to you, Neil, especially, but also to today's panel members, Vuong, Gosia, Aruna and Edward. I mean, as a group, you've given freely of your time today and have also spent large numbers of hours researching, creating and reviewing the published guidelines. I know that there's hours and hours of work there. There's a huge literature search that's been done, and all the salient worldwide literature is included in the guideline. So I feel that your collective knowledge and expertise have really contributed to today's excellent discussion, and also the guidance document that I think will support many of our laboratories into the future. So I really, if you haven't done MRD work before, I'd really, ask you to take the time to look up the ACS website where they're freely available. And in final closing, I'd really like to thank Sheree very much for her excellent on-screen management of today's sessions. I am completely a computer phobe, apart from just the work that I need to do on it. So we won't have made it through without you, Sheree, so thank you very much. Sheree, do you have any final closing comments?
Thanks, Michelle, for your kind words. I'd also like to thank our panellists for participating in ACS Hour and for all of their efforts in developing the ACS guideline for MRD. Thank you to Michelle for producing and moderating this episode. And to our audience, stay tuned for our next episode of ACS Hour in September, followed by a special hour in October. So thank you to our audience for listening. Back to you.
Thank you very much.
Thank you.